Hello, my name is Janet Hawley, and today we're going to be talking about HIPAA, the Health Insurance Portability and Accountability Act, the HITECH Act of 2010, and the Administrative Simplification Regulations of 2013. The process today is that you will view this HIPAA HITECH PowerPoint presentation. You should also have a copy of the policies and procedures, which include the corrective action policy for students and reference to the corrective action for staff and faculty. You'll take an exam. By the way, that's an open book exam, but you must receive 80% or better and to pass. Then you will, within a week or so, receive your department certification of completion of HIPAA training form. HIPAA Overview. Although confidentiality has been a part of healthcare since Hippocrates, the HIPAA Accountability Act was enacted in 1996. It created national rules regarding patient rights to privacy, security, as in taking care of records, medical records, and access to healthcare information, i.e. patients' access to their own healthcare information. It imposed duties and responsibilities on healthcare providers, health plans, and healthcare clearinghouses, and these are known together as covered entities, to safeguard healthcare information. If confidentiality was always the norm, you may be asking, why have a privacy rule? Well, Congress recognized the challenges to confidentiality of healthcare information due to the increasing complexity of healthcare industry and by advances in health information systems, technology, and communication. For example, there are many activities that are being used with healthcare information, such as billing, research, quality assurance activities. All of these people and processes are involved in getting into the medical records. The sheer volume also was we were going away from paper records in favor of electronic records. As I noted in the previous slide, there's an issue with the number of people who have access to your protected healthcare information. For example, if you were to do something that is commonly known as stupid here in the desert, our stupid motorist law, if you and your son decided that it would be a fun thing to float down the river after a big storm here in the summer, and you ended up needing to be rescued and got picked up and taken to the emergency room, who all would know about your ER visit? Well, the first responders who came to get you in the ambulance or the helicopter. Then within the ER staff, there's nurses, physicians, medical techs, administrative assistants, the lab tech who draws your blood. Then if you're doing a shift change, there's even more people. All the personnel who transport you back and forth from radiology, for example. The bilingual billing staff, who set up your account. Coders who review your records. You might get some medication while you're there, so the pharmacist or pharmacy tech see your records. The insurance company certainly reviews this admission. So I in fact heard recently on National Public Radio, if you're admitted to the hospital, there may be up to 116 individuals who interact with your records per hospital visit. This little cartoon just again alludes to the various technologies we use to pass health information around. So somehow your medical records got faxed to a complete stranger. He has no idea what's wrong with you either. Multiple users have access to protected health information, even in speech-language hearing clinics, a little closer to home. So within a clinic like ours, we have the receptionist or scheduler, the medical records department, which usually is a department secretary, admissions, another clinic secretary perhaps. We may have a transcriptionist who's sending or typing reports for us. The healthcare providers themselves are audiologists, speech-language pathologists, In our case, we may have a student in training who's a healthcare provider, such as a graduate clinician or a speech-language pathology assistant student. There may be a researcher who's accessing the records. So even here, we have quite a few people who may have access to records. The bottom line for the Healthcare Portability and Accountability Act is that covered entities, and that's us, speech-language pathologists, speech-language pathology assistants, and audiologists, must take reasonable steps, and that's defined in the guidelines, to safeguard the confidentiality, the integrity, and the availability of protected health information that they create, that they receive, information that's sent to us, and that we maintain. So who must comply with HIPAA? Well, as we mentioned previously, the covered entities, the health plans, for example, United Healthcare, Blue Cross Blue Shield, the healthcare providers, and that's defined as not only the healthcare provider, him or herself, but also those individuals who must also transmit data electronically in connection with standard transactions. In theory, if you are not doing electronic billing, you would not be considered a covered entity, as well as healthcare clearinghouses. There's also what are known as business associates, and these are entities that provide services on behalf of a covered entity, especially those that involve possible disclosure of protected health information. Examples of that would be transcriptionists and billing companies. As a part of HIPAA, there's a category called Administrative Requirements, explaining what the covered entities must do. First, we must appoint a privacy officer. At the university, we have Andrew Mahler, who is our university-wide privacy officer, and within our department, I serve in that capacity. We must provide HIPAA training for staff, students, faculty, anyone who comes in contact with medical or protected health information. We must implement the policies and procedures. Of course, we must safeguard PHI that we create, receive, or maintain. This includes physical safeguards, such as privacy screens or having that gap between where the secretaries admit patients and back behind there where they keep the private information, and electronic safeguards such as password protected computers. We must investigate complaints if a patient has a complaint of any kind, and as a part of that we must refrain from intimidating or retaliatory acts. So if they complain, there must be no indication whatsoever that we would in any way try to come back at them for complaining. We also must establish sanctions for failure to comply with the privacy rules. So I have mentioned this term PHI several times. What exactly is PHI, or Protected Health Information? Well, this is defined very clearly as individually identifiable health information that relates to the health or condition of an individual, the provision of healthcare to an individual, or the past, present, or future payment for the provision of healthcare to an individual. What is very clear is that this PHI, or protected health information, must be safeguarded, whether it is oral, written, or electronic. There is a long and exhaustive list of PHI. Some obvious ones like names and medical record numbers, social security numbers. Some less obvious ones like vehicle identification numbers or license plate numbers. And some that may become more common in the future, some of the biometric identifiers like voice prints or fingerprints. But you can read this exhaustive list. So, privacy and security standards for protecting protected health information. As you can see from your policies and procedures that you have, we have a number of policies that are important to follow in our clinic. We have a public area policy that describes where you can and cannot discuss protected health information. For example, obviously elevators and waiting rooms are not appropriate. Clinic rooms and clinical instructors' offices, the SpongeBob lab, those are all places that are compliant. Our hard copy communication policy, which talks about how we take care of our charts and the records that are within them, where they're allowed to be kept. they're locked up at night, our oral communication, where we talk about what's appropriate to say on the phone when you call a patient or in person in the clinic waiting room, for example. We have email policies. Generally, we try to avoid at all costs sending any protected health information via email, but if we have everyday kinds of scheduling concerns, that's something that with the patient's permission we may send via email. And also all of this follows the minimum necessary rule, which we will go through in depth. Security of patient files. As a part of our guidelines, we obviously must be able to treat our patients, so we must have access to their medical records. However, it is prohibited to remove files, paper or electronic, containing PHI from the department building, the Autism Extension Office, known as ACE, or the Child Language Center, also known as WOW. The exception is that clinical instructors or faculty and authorized clinical staff may transport files for professional purposes, for example, report writing. These files must be properly secured and labeled confidential during transport. General HIPAA rules. As a part of HIPAA, there are a variety of categories that we must attend to. The minimum necessary standard, which we will go into next, information about authorizations, the rights and rules regarding parents and guardians, guidelines for the use of protected health information and marketing materials, as well as patient rights. One very important standard is the minimum necessary standard. This permeates HIPAA and daily practice. For example, all staff, students, affiliates, and volunteers must make reasonable efforts to limit the use and disclosure of and request for protected health information or electronic protected health information to the minimum necessary to accomplish the intended purpose. For example, the receptionist in the clinic doesn't need to know details regarding the client's condition, just enough to schedule the appropriate type of evaluation. Putting the minimum necessary standard into practice. Here are some good examples. With the phone communication, we leave the minimal message that we need to leave in order to accomplish our intended task. When we have patients check in, we don't state their diagnosis in front of others, obviously. We also have a preference for communication form. You may have filled these out at doctor's offices that indicate would you like to receive your messages on your cell phone, via email, on your home phone. This is a way to give the minimum necessary information to the patient with their protected health information. Our greeting protocol, again, we're very careful when we greet patients to not divulge any protected health information. When we do feedback with our patients after an evaluation or therapy, we should always go back in a private room if we're going to have any extended conversations. But for example, in terms of minimum necessary, you may walk out and greet the parent after a session and say, he had a good session. And that would be the minimum necessary to accomplish your intended task without divulging more specific information. We also have procedures that are very specific about where we can share information in the clinic with families, as I mentioned above. Treatment, payment, and healthcare operations. This guideline from HIPAA allows us a little more leeway to take care of our daily tasks. HIPAA permits covered entities to use or disclose PHI for treatment, payment, or healthcare operations. For example, in order to treat a patient, you may need to communicate with them about their appointment, or you may need to bill them, obviously. So information may be divulged in those cases. Specific authorization for use or disclosure of PHI for TPO is not required for these purposes, but the department must inform patients that their PHI will be used for these purposes. Now let me give you some more examples of treatment payment operations. For example, a speech-language pathologist may disclose the results of a modified barium swallow evaluation to the referring speech-language pathologist or doctor. This falls under the category of treatment. Similarly, an audiologist may discuss medical concerns regarding a patient with the patient's ear, nose, and throat doctor. Again, treatment. The clinic, the provider, may submit a bill to a patient's insurance company. This falls under the category of payment, and payers always have the right to see the patient records. Also, we may review charts as part of quality assurance. This falls under the category of operations. HIPAA authorizations. Except as otherwise permitted, for example in the TPO examples I just covered, a covered entity may not use or disclose protected health information without an authorization that is valid. A valid HIPAA authorization must include language mandated by the rules and include core elements required by the rule. This includes such things as date and the length of time that it's in effect, for example. Authorizations, as you may well be aware of from your own private healthcare information, are required for a release of information to send records, for example, to send an audiogram or report to another party from our clinic, or release of information to receive medical records. In this case, we ask the patient to sign it so we can request records to assist us in treating them. For example, getting a copy of their records from inpatient rehabilitation. So basically, the patient releases information to go from one party to another, a legal document. There are some cases in which it is permissible to use and disclose PHI without authorization. These cases include cases where it's required by law for communicable diseases or child abuse, disclosures for public health information such as vital records, or again communicable disease tracking, disclosures of information records to a school. So in these cases, we do not need to have the patient or client sign an authorization form. There are also specific HIPAA guidelines regarding the ability to disclose information to parents and guardians. By both state law as well as HIPAA guidelines, results can be discussed with parents and authorized guardians. We sometimes run into challenges when we have divorced couples and we need to be sure that both parties have authorization to receive this information. As in terms of adults, typically if they bring friends or family, it's the best policy to ask them at that point, is it okay if I go ahead and talk about your treatment today in front of this person? That's the safest thing to do, and if you do that, then you should document in the records that the patient gave verbal authorization. Ideally, it would be good to get a signed authorization form in that case. Another category that HIPAA is very clear guidelines about are patients' rights. HIPAA confers a number of rights to patients, which include the right to a written notice of privacy practices from providers and health plans. You may find that this actually doesn't occur in some offices that you go into. I find that they say, sign here, you've received the privacy practices, and then they don't necessarily show you them, but you should get a copy of the privacy practices when you sign that piece of paper. Patients have a right to inspect and copy their protected health information. There are specific guidelines regarding mental health notes, but they do have a right also, as a part of the Simplification Act, to an electronic copy of their records. They have a right to request that the covered entity amend information in the record. So we have specific information in our policies and procedures regarding how we handle a request for an amendment. So for example, if a patient says you got information wrong that you put in the report, we would need to take that under consideration and make a decision if we would want to amend the record. We do not go back and change the original medical record because that is a legal document that's now complete. Patients also have the right to request restrictions of the use and disclosure of their protected health information. So in our case, we ask that they allow us to share information sometimes in classes with students, and they do have a right to deny that to us. I'm done. There are a number of other rights that are covered by the Act. Patients have a right to have reasonable requests for confidential communication accommodated. So, for example, if they would like us to call them on their cell phone with lab results, that might not be us, but rather than on their home phone. They have a right to file a complaint with the service provider if they feel that they did not get appropriate services or that their records were not kept, that their records were inappropriately disclosed. They have a right to file a complaint with the Secretary of Health and Human Services, in fact. In our policies, we indicate to patients that we would like them to start with the clinical instructor, the closest clinical provider, and then if they do not reach satisfaction, they can go to our department head. We do all of this hoping that we can avoid having them go to the Secretary of Health and Human Services, but that is their right. Patients also have the right to request that their medical record not be sent to his or her health insurance provider if he or she self-pays for service. This again is part of the Simplification Act, and it recognized that sometimes patients did not want their records sent, but if their payment is handled by insurance, then it does get into the healthcare clearinghouses. So if they self-pay, they have a right to request not having it sent. They also have a right to receive an accounting of the disclosures made of their PHI. So we have a form that allows patients to fill out and ask for that disclosure list, and we should be keeping really good track of where we have sent patient records and what authorization forms we have associated with that. Electronic records. As noted earlier, as part of the Simplification Act, which made it more specific, clients and patients have the right to receive an electronic version of their PHI. Although we do not routinely send PHI through email, if we have a specific request from a patient or client, we do have the ability to send encrypted PHI through the UA Connects accounts. This only works for UA Connects to outside the system, not from UA Connects to another UA Connects account. The alternative to that is to have a patient sign an authorization acknowledging that they give permission and understand that there is a risk if their private information is sent via internet. Physical, technical, and administrative safeguards. HIPAA requires that covered entities establish physical, technical, and administrative safeguards to protect the confidentiality, integrity, and availability of PHI. Physical safeguards. Much of the next several slides will be most applicable to graduate clinicians who are working in the clinic. We have a variety of safe clinic areas to use and discuss PHI. These include the clinical computer lab, which by the way is password protected. Each and every person who enters there has their own private password. The speech language hearing clinic office on the first floor. We also have a clinic workroom down in room 107 where you can share information about your patient or look at patient records. The audiology suites are obviously an area that's safe to discuss PHI. Therapy rooms on the first and fourth floors. Of importance is that there are mailboxes specifically in the computer lab and the clinic office that are physically safe places to put patient information. However, mailboxes on the second floor are not. Those are for regular everyday type mail and daily kinds of things in the relative to graduate school, not to patients. There's also a disaster plan that talks about how we would protect health information should there be a disaster, including such things as closing down computers and locking the cabinets before leaving the building. In terms of the technical safeguard aspect of HIPAA, we have several examples here, ways that we protect technically. Each individual who accesses electronic PHI has a unique ID and password. So for graduate clinicians or clinical faculty, each person has unique ID and password for our electronic medical records. We encrypt PHI when we need to send it out. I'll talk more about that later. We have very strong password requirements by the law as well as by choice. We change passwords regularly at an interval basis to ensure that we keep the highest standard of safety. We also have firewalls. We have medical records that are generated by providers on the fourth floor lab that are sent down to the first floor via firewall protected systems. Continuing on with technical safeguards in our speech-language hearing clinic, our computer policy states that no client patient information may be placed on hard drives, removable medias, or PDAs. This is something that we can't completely physically control, but it is an extremely important part of our privacy policy. As you may know, all of our confidential client patient information resides on the clinical servers known as SpongeBob and LITech. These further, we have some guidelines in terms of ensuring that students log off all unattended computers when they walk away from them, and the computer will time out automatically after a while, but of course it's best to log out before you finish, when you finish. Of note, all of our clinical computer labs and our department systems can be audited. For example, as I mentioned before, each graduate clinician who's working in LITech and clinical faculty receive their own code, password protected code to go into that room. Thus, if you were the last person in the room and something occurred in there, we would be able to audit that. As I mentioned earlier, HIPAA includes administrative safeguards. These include having policies and procedures available and written up in your department, in your clinic. You must also train all students, faculty, and staff on an annual basis. Thus, if you've done this before, we appreciate you doing it again. It is required. We also have to have policies that include sanctions for failure to comply. All students, faculty, and staff must follow through with these procedures, and if not, we have sanctions in place, which I will go into in a minute. This next slide, safeguards relative to student observations and training in the clinic and classes, is relevant for both graduates and undergraduate students. All students must receive HIPAA training prior to observation in the clinic. Only client-patient initials are used on lesson plans and schedule boards in the speech-language clinic. This ensures that patients' protected health information is protected. Audiograms may not be copied for academic purposes unless de-identified. So sometimes it's best to just have a blank audiogram and copy the record onto that. Videos presented in class or posted to D2L, which is not recommended because one could open that at home and other people could come by and see it. So we discourage faculty from putting up videos on D2L. But videos presented in class are held to the same high standard of confidentiality as live observations. So you wouldn't want to go home and talk to your significant other about the person that you saw, particularly if you shared any information that might help to identify who that person was. Now we're going to talk about a breach of protected health information. A breach means the acquisition, access, use, or disclosure of protected health information in a manner not permitted, which compromises the security or privacy of protected health information. So this not only means releasing information inappropriately, letting it get out into the public eye, but if, for example, a famous person comes into a hospital and you're interested in finding out what happened to them, you should not be able to access their records unless you are on, a provider for that case, or someone involved with their care. A breach may be intentional or unintentional, and as you'll see when we talk about violations and fines, even unintentional breaches have consequences. Any breach may result in sanctions, that is, disciplinary action, against the individual who commits the breach. Here are some examples of breaches that might occur in our clinics. If, for example, you left a client's report on the couch in the waiting room, or you took a client's chart out of the building, those would be frank examples of breaches. Can you stop for a minute and think of other kinds of verbal or visual breaches that might occur? Something like, for example, talking about a patient in front of other people on the elevator. Now I'm going to talk about our corrective action policy for breach of client-patient confidentiality by undergraduate students. For the first offense, whoever observes it files an incident report. This incident report then goes to the course instructor if it's a class, if the disclosed PHI was seen in a class, or to the privacy officer if it's related to an observation in the clinic. Step 2 of the corrective action procedure is should another breach occur. In this case, there's a written warning placed in the student file, and there's a conference with the course instructor and the privacy officer once again. This conference is designed to provide information to the student to ensure that they understand the severity of their action. The next step in the policy occurs if there is another breach after the written warning. In this case, the student is suspended from class participation and receives a failing grade. So this is a very important process to monitor. This next slide has to do with graduate student corrective action policy. In this case, if a breach occurs, whoever observes it files an incident report, and step 1 for graduate students is they would have a conference with the clinic faculty associated with the client that the information was disclosed. The clinic faculty would educate the student and inform them of the severity of their behavior, with the attempt to avoid having this occur again. The next step of the corrective action policy regarding graduate students occurs if there is another breach after the first, or even a potential to expose protected health information. In this case, there is both a written warning placed in the student's file, and they have a conference with both the clinical faculty and the privacy officer, once again reiterating the importance of protecting patient information, and what the next step will be if they do not comply. Step 3 for the corrective action that occurs for graduate students has to do with if there is a breach following the written warning. This is very serious, and in fact the student is then suspended from practicum for a duration of 1 semester, and they get an incomplete grade, and their clinical hours are not counted towards ASHA. If a permanently suspended student will not be recommended for ASHA certification. Step 4 of the procedure is we go into step 4 if a pattern of continued disclosure is evident. The consequence for a graduate clinician who commits a breach or even a behavior that has the potential to compromise confidential protected health information after they've been suspended from clinic and they continue to show that pattern, they will be terminated from our program. Not only do we have sanctions because they are required by the HIPAA Act, but also because there are significant monetary penalties. For example, if the covered entity did not know and exercise reasonable diligence, they still failed to protect patient health information, protected health information, they would receive fines of no less than $100 and up to $50,000 per violation. but not more than $1.5 million for identical violations per calendar year. The reason this is so large is because there generally tends to be a pattern where a large number of patient records are not cared for well. There are also civil penalties if the client covered entity demonstrated willful neglect, but they did correct it within a 30-day period once they knew. In this case, the fines are no less than $10,000 per incident, up to $50,000 per violation. Continuing with penalties, and this again is very detailed, I'm sorry, but this is how the guideline's written. If it's due to willful neglect when some PHI is disclosed and the covered entity knew that it occurred and didn't rectify the problem within 30 days, it's no less than $50,000 per incident and no more than $1.5 million per. There are also criminal penalties. So we not only have fines, but the potential to be incarcerated. This is all enforced by the Department of Justice. Now I'd like to go through some scenarios from our clinic to help you get a better sense of how all of these policies and guidelines go into play. Scenario A. A mother has diminished hearing. Her daughter, who lives out of town, makes an appointment with the hearing clinic. Mother goes to the appointment and orders a hearing aid. The daughter wants to follow up with the audiologist for information and progress updates. Under HIPAA, is it okay for the audiologist to contact the daughter? Think about that for a minute. So the standards were on the previous slide for how you would make determination, and one example of a solution for this scenario would be that the daughter in fact could contact the audiologist with the mother's consent, but the audiologist should secure consent, ideally written but even oral, before disclosing PHI to the daughter. He should document this. He or she should document this authorization or this oral approval. But if the authorization is not obtainable, for example, if the patient has dementia, the audiologist should use professional judgment before disclosing PHI. Scenario B. In this case, let's say the mother has diminished vocal strength, or let's say aphonia, and receives a communication device from her speech-language pathologist. Several months later, the device is not working properly, but the patient obviously can't communicate over the phone with her particular device. The daughter once again calls the clinic to discuss the case. Is it okay for the speech clinic to provide the daughter with the needed information? Solution for scenario B. This one's actually very similar to the last one. The speech-language pathologist should determine if the mother gave permission to have her daughter discuss and contact the clinic. An ideal way to know that is the daughter has specific information about the communication device. She knows the ID number on it or the specific device. This would indicate that she's in close contact with her mother and is calling on her behalf. Once the provider, the speech-language pathologist, has determined that it is an appropriate thing to disclose the information needed, particularly with minimum necessary guideline in mind, this contact and the oral communication that occurred should be documented in the patient's chart. Scenario C. This one's near and dear to my heart because I'm involved in the aphasia groups. We often will have adults with chatty spouses. So they'll want to be talking about their spouse in the waiting room with other family members, with other spouses. Or they want to talk with you about their spouse in the waiting room and ask you specific questions. How do you handle this? So to talk about sort of the quote-unquote solution again for scenario C, well, of course, our policy is that no protected health information about any client or patient should be discussed in any public area. Ideally, the family members should be brought back into the clinic or some other secure location before detailed information is discussed. However, if oral consent is given, the minimum necessary information may be shared. This again should be documented in LITEC that the patient or client indicated that it was okay to talk in the waiting area. These are challenging situations there, but it's important to remember that we are trying to advocate and model for our family members, the kind of behavior we would like to have, if we were being treated in that way. Bottom line, we have a very specific plan in place to protect our patient and clients' protected health information. Remember to avoid knowing disclosures. Obviously, you've now been trained and you should know the policies and procedures and the things you should not do that you should do. But be very vigilant so that you don't do any incidental disclosures as well, any of those unintentional kinds of things. So that means you need to be very vigilant whenever you are walking around with, hard copies of paper, or if you're using electronic information, or if you're talking to family members in the waiting room, for example. So one more quick thing to discuss. We're almost done. This has to do with the use of protected health information for research purposes. Privacy and security standards for protecting PHI relative to research and program development. HIPAA allows for clinical entities to perform chart reviews for research purposes, for recruitment purposes, without prior authorization from the patient, but only if the patient is notified in advance that such a review may occur. So when our patients check in, they sign their consent to treat, and on it it's acknowledged that their chart may be reviewed for research purposes, but that they will not be used for research purposes until they give permission to do so. We also have guidelines for program development. So our procedure for handling clinical research is that the individuals who are interested, need to be part of our department, of course, who would like to have access to clinical records, must first fill out a request to access clinical records form. This can be obtained from Denise or Stephanie, and it's also located on the faculty website. They submit this form to the privacy officer for approval. Once approved, the faculty who's involved in clinic faculty or academic faculty who are involved in reviewing the charts must maintain a log of the clients and patients the charts they entered, and note that they accessed the chart, the date they accessed it, the purpose of the disclosure, and the nature of the information disclosed for each chart accessed. Once they've completed this, they must then submit the completed forms to the privacy officer. So they both enter into the chart itself or into LITEC that they were in the chart looking to review it for research purposes, and they must maintain a separate list of all the names of charts that they entered for that purpose. I'm sure you'll be happy to hear that this is the end. I appreciate your time and your attention during this long process, but it is mandated through HIPAA that we have annual training for all personnel, be employees and students, who are in any way involved in protected health information. Be sure that you sign the confidentiality agreement form and that you complete your test. Within a week or so, you should be receiving your HIPAA certification form. Thanks again.